Okay.
Yeah, hi, good evening. Mihir, over to you. We are live.
So, very good evening to all the viewers of this pre-WIROC 2024 webinar on shoulder arthroscopy. I thank the organizers of WIROC to give us this opportunity to organize this webinar. And I also thank all the faculty members here, namely Dr. Aditya Pavaskar, Dr. Fayaz Memon, Dr. Sunirmal Mukherjee, Dr. Abhishek Nerurkar, and Dr. Chadri Usman today to be present today evening so that we can make this webinar success and try to get as much information about the skills of shoulder arthroscopy across to all our delegates. So without wasting any time, I would like to invite our first speaker, Dr. Fayaz Memon, who's going to talk about basics of shoulder arthroscopy and making of portals. Fayaz?
Yeah. So just hold on. So good evening, everyone. I'll just try and share my screen. Yeah, so can everyone see my screen?
Yes, Fayaz, we can see and we can hear you.
Yeah, so today I've been interested with this topic, arthroscopic portals for shoulder. And as we all know, shoulder arthroscopy is all about doing larger stuff through smaller portals. So your portals need to be in perfect place depending upon where and what you're operating. As we all know, shoulder arthroscopy is, these are my credentials, and just hold on. I think, yeah, are you sharing the screen? Yeah. Yes. Can anybody help me share this screen? Can you see this screen? Yeah. Yeah, I guess this
Yes,
is.
we
Yes,
can see.
Fayaz,
Please go ahead.
your screen is moving. You can go ahead.
Yeah. So shoulder arthroscopy is all about having right portals at the right place so that our trajectory and our procedure go seamless. If we falter into this, it's going to be trouble and you'll keep struggling during your surgery. We should remember one thing, that shoulder joint is not exactly below the acromioclavicular arch. It is slightly anterior. So once you have this idea, it's easier for you to get your portals right. I usually prefer all my shoulder procedures in lateral decubitus position, and I use an interscalene block along with general anesthesia. So we know that we use this shoulder position wherein the surgeon stands behind or on the head end. Never we go on the anterior aspect. So anterior aspect is for the trolley. The table height should be at the level of the elbow of the surgeon so that you don't get supraspinatus tendinosis for yourself. And of course, all the other things what are required. Most importantly, the plastic apron and the impermeable long leggings. Having said this, there are two types of portals. One is subacromial portals, the set of portals which is required for the subacromial procedures, which cannot be said as arthroscopy portals, but shoulder endoscopic portals. But for convenience, we call them as shoulder arthroscopy portals only, or subacromial portals. So these are the portals that we can see from here. I'm going to show you the video. And this is the live case in which I'll be demonstrating the shoulder. In case if you guys are not able to hear the volume, please let me know. Then I'll have to start with the proper commentary on this video. So this is the lateral decubitus position. I'm standing on the posterior aspect of the patient. This is everybody could hear this video volume.
Yes, we could hear it.
Okay. Right.
Yes, sir.
This is the head end, that is the leg end, and this you can see here is the traction table where I can easily internal, external rotate it, or I can lift it if required. Now, when you're taking the portal, you have to just start palpating from here, and the first bony prominence is the posterior aspect of the acromion. So you just mark it over here, and then you just palpate it on the lateral aspect and just go anteriorly and see where is the other corner, the anterior corner, and that you can find it over here. Okay, just connect the two dots as per the lateral aspect of the acromion. Now here you can continue palpating. This is the acromioclavicular joint. Here you palpate the concavity of the clavicle and just extend your marking over there. And then here you can find the continuity from this first point that we took for the spine of the scapula. So this is how it is. Now, for these margins, again, you do the same thing and take it over here, mark your acromioclavicular joint over here, and then the superior aspect of the spine of the scapula. So this is our arch, which is most important. Then the second thing that you do is, in the maximum concavity of the clavicle, you just try and palpate. Here there is a bony prominence, and that is nothing but the coracoid process. So now, depending upon what surgery you are doing, you are going to mark your portals, whether it is intra-articular or the subacromial. Okay, I will show you the intra-articular portals first. Any shoulder arthroscopy, whether it is subacromial or intra-articular, always the arthroscopy starts with glenohumeral joint. So you have to first put the scope blindly, the trocar and the cannula blindly. So the first portal is about 2 to 2.5 centimeters from the posterior corner of the acromion, which we marked the first. So this is 2.5 centimeters down and 2.5 centimeters medially. Now this is not always for every patient. It depends upon acromion to acromion, scapula to scapula. But by and large, this is a marking. Then in case if I am doing a Bankart repair, say, so it is going to be a glenohumeral joint procedure. So the next one that I do is anterior portal. So this is just going to be little laterally and little inferiorly. Next portal. However, this I'm marking here because once the joint gets inflated, maybe the bony prominence might not be seen. So I'm just marking. However, whenever you are doing the arthroscopy, you visualize it from inside, palpate it with your finger, and then put in a needle, and then take the portal. Remember that here you are very near to the subclavian artery. So one has to be very careful about that. And the third portal that we require in case of a Bankart repair is this anterosuperior-lateral. It is just at the corner. So you just insert from here inside the joint, and you find that it is going through the rotator interval. Now, when you are doing a subacromial procedure, what you have to do is just draw this line, okay, and mark 4 centimeters from the lateral edge of the acromion, because below this you are going to encounter the axillary nerve. So you just do that, and then this is the safe area fairly. So anterior, posterior. So you can have as many portals over here. I'm just trying to simplify. And if at all you require, you can take a portal from here also. But that is rarely required. Along this surface of the acromion, you can have a couple of portals for the insertion of the anchor whenever you need for the rotator cuff surgery. Before taking the incision, always try and palpate the humeral head. So you have an idea as to where is the glenohumeral line over here. In this case, we are right at the point. So just take the incision deep enough to reach the muscle. Then just go inside by twisting force, rotate, and reach the glenoid. Now I can feel the glenoid and the humeral head over here. Little abduction, move, and just enter the joint. Now, after you've confirmed that you have entered the joint, just see whether it is able to go vertically. And here I am able to slide. So now I'm inserting my scope inside, and you can see that I'm inside the joint. So this is the glenohumeral joint. This is the glenoid, and this is the humeral joint. Once you're inside the joint, just try and palpate where you are. Okay, and here you can have a little amount of movement. So once I put my needle over here, it should come. This is the case of a rotator cuff. Okay, so this is the cuff here, and here I can see. One thing that you must remember in case of a shoulder joint is do not remove the needle that you put. First, take the incision exactly along the line of the needle insertion and see that the tip of your incision has come out inside the joint here. And then you remove your needle. So once we've finished our glenohumeral diagnostic arthroscopy and identified the pathology, we can utilize the same portal, this time not going inside the joint, but going in the subacromial space. So you just direct your cannula towards the acromion, hit the acromion, just go little down and insert it parallel, and you will find that you are in the subacromial space. Next is the shoulder arthroscopy portals for the glenohumeral procedure, something like Bankart repair. So now this video is going to show you how we take the glenohumeral portals. This is a entirely new setting where is the patient head end, leg end. That's anterior. I am standing to the posterior of the patient. This is the right shoulder joint. This is a Bankart repair surgery, which is a glenohumeral procedure. That's why I have just marked these 3 portals which are required. If required, we can have other portals. This is the Coracoid process. This is my posterior portal, which we start from. This is anterior superolateral portal. This is the anterior portal. So now I am in the glenohumeral joint. This is the biceps tendon, as you can see there. I'm going to look there and try and palpate my finger. So I know that I'm going to come from that area, which is the rotator interval. I'll just take this long needle. So when I'm inserting, I'm seeing my needle over there. I should be able to see whether the trajectory is correct, and I'm able to reach the inferior area of the anterior glenoid. Now again, I'll keep my needle there and try and take my incision along the line of the needle. So I should be able to come right next to the needle. So I know that I'm in the safe zone. Once my incision is done, I put my Bissinger rod along the same track so that I can insert my cannula. Now I can remove my needle safely. This is that anterior superior lateral portal. From this portal, when I just put my needle, comes right inside the joint through the rotator interval. Now again we'll see there. I can see my knife coming there inside. This is my switching step. So here, before beginning the surgery, I have secured all my portals which are going to be required for this particular surgery. You can always put in a cannula or over the switching seat. I have kept 2 trocar cannula. So I remove the trocar and just shove this inside the joint so that I have little error and my time is not wasted. So having put this, you can see there, my cannula has come inside. I'm going to view from this portal, and this portal will be used for suture management, and that will be the working portal. Now I'll put my scope over here and start my procedure. So I have taken the saline flow in this cannula, and now I'll be able to watch the glenoid. This is the glenoid from the superior aspect, and this was my original portal. this completes our glenohumeral and subacromial portals. I thank you very much for your kind attention. Are we taking the questions now?
Yeah, Faz, thanks so much. If we have some questions, we can take them. I can actually request the faculty to ask some questions on behalf of the delegates, because on the YouTube link presently, I cannot see a lot of questions being asked because your talk was absolutely clear, to the point, very practical, very usual of Fayaz.
Thanks.
So Fayaz, a little question from my side.
Yeah.
We have a lot of cannulas available in the market, very small practical question. So
Yeah.
what cannulas usually you prefer, your to-go cannula, say, which size, length, if you can, just put a little picture on that before we ask
Yeah.
Aditya to start the
So
talk.
for the anterior one, I use this 8.2 millimeter cannula that's available. And for the
Okay.
posterior one, I use this 5.5 millimeters. But for the superior one, earlier I used to use a cannula, but I found that it becomes too big. So directly shoving in our trocar cannula or the camera, as I showed. So I keep two trocar cannula for a bankard repair, so I don't waste time in doing the blind procedure to reach that target. So one 8.5 or 8.2, whatever is available, and one 5.5. So all my procedure, whole of my procedure is from the anterior superior lateral portal, viewing from there. My initial beginning of the procedure starts from the posterior portal. Anterior portal is always for the suture management and taking the bites to the tissue.
Okay, so I would request, before I ask the next question for us, Aditya can start sharing his screen. Fayaz, what choice of scope do you use? I mean, what degree scope do you use? Any time that we need a 70 scope or any other angle scope when we are doing
So
shoulder?
earlier I have used 70 degrees scope to see the Hagel lesion, but now I don't find any reason to take a 70 degree scope. I always use a 30 degree scope. So very rarely where I have to reach some corner which is not visible, but usually it's 30 degree scope only, 4.5 mm.
Okay, so Aditya, are you sharing your screen?
Yes, I'll be sharing my screen here.
Okay, so you can start doing that. In the meantime, I will ask one more question to Fayaz. Fayaz, do you always use the arthroscopic pump for shoulder, or what are your choices when you would not do it? And if you could just throw a little light on the pressures you use.
Yes. So for a glenohumeral procedure, I don't use arthroscopy pump. I just use the hand pump wherever required. So if I'm not able to see or there's some blood or something, I just ask my assistant to pump a couple of times, and it is just normal gravity that works. But if it is a subacromial portal, I require some space wherein I can keep the deltoid away from my working place. So there I use this arthro pump. And earlier when we were learning, it was too high a procedure that we used to use 80, 100, whatever. But now we just 35, we start maximum that we require, if at all, it goes up to 45, otherwise 35 is good enough.
Correct. Well, the second thing is, Fayaz, what we understood, and because I know you since so many years, your preferred position is lateral.
Yeah.
So could you throw a little light on the beach chair position? A lot of surgeons were using the beach chair position while doing the arthroscopy.
Yeah, in case of beach, I mean, it's all surgeon's preference. There is no my way or highway kind of thing. So whoever is comfortable, it all starts when you're trained. So if you're trained in a lateral position, you're comfortable doing all the procedures in lateral position. Only arthrolatergit is one position where I feel is a beach chair position compulsory, at least as of now. But otherwise, all the procedures of the shoulder can be done in lateral decubitus position. Only arthroscopic, I'm not talking about arthroplasty, only procedures. So it all depends how you have been trained. In beach chair position, there is little extra risk of throwing some embolus or something into the carotids and all. So that's the reason I was always afraid. And now we've developed ourselves to do all the procedures except for arthrolatergit through lateral decubitus position. So by and large, even when we are in the lateral decubitus position, I don't know, somehow it has happened, and I'm sure everybody of us who's regularly doing arthroscopy, when you're doing a glenohumeral procedure, your camera tends to be straight. So the glenoid is down and the humerus is up. But as soon as you go into the subacromial space, the camera turns in such a way that the glenoid is, the cuff is down and the arch is superior. So bone is, the acromion is superior. So actually, by holding this way, you have the orientation of a vertical position only. So
Absolutely. I think, Fayaz, that was a very relevant point, that keeping a camera in such a way that when you see the monitor, the orientation is always anatomic, be it beach chair or lateral position. I think that was a very important point. I think Aditya is ready with his talk on diagnostic shoulder arthroscopy. Aditya, you can start your talk.
Sure. So Mir, what I've done is I've recorded my talk earlier. Just, sometimes there are network issues and all. So I'll just be running the video.
Okay, great.
Hello, everyone. My name is Dr. Aditya Pavaskar. Today, we'll be speaking about what are the things that you need to do when you put in your scope into the shoulder, and starting off with your diagnostic shoulder arthroscopy. So make it a habit. When you make something a habit, it is said, that's one less decision that you need to make. So when you apply that to shoulder arthroscopy, make it a habit to go around the shoulder, have a checklist of the points that you will make a note of, because your MRI may say anything. You may have made a decision about what surgery to make, but you don't want to be left with a surprise. And that's why having a checklist, going through those points of interest will always benefit you. Now, initially, you may find that you have to go through it in your mind that, have I checked this point? Have I checked this point? But like I said, make it a habit so that after a while, it does not need to be a decision. You just only go through the joint around those points. So I have borrowed this video from Leonard Funk. This video is freely available on YouTube. I borrowed this because it just makes things very simple. What are the things that you need to do when you go into the joint? So the first thing that you need to check is your long head of biceps tendon for any slap tears. The second is the posterior glenoid and the glenoid and the posterior labrum. The third is the inferior recess or the axillary pouch. Fourth is the posterior aspect of the humeral head, the bare area, and the posterior cuff. The fifth is your anterosuperior cuff. Now you come into the anterior part of the joint and you see the rotator interval for the pulley, long head of biceps, and the superior glenohumeral ligament, the subscapularis, middle glenohumeral ligament, and the labrum, the antero-inferior labrum, and the IGHL next. Then you go into the subacromial space to see the coracoacromial ligament and the acromion, and lastly, the bursal side of the rotator cuff. So let's start by this video. So the first thing that you're seeing is the long head of biceps origin, where you are observing for any slap tears. Then you move on to the posterior aspect of the joint. The first thing that comes into vision is the articular surface of the glenoid. On the left and on the right, you can see the humeral head. At the center, roughly, of the glenoid, you'll see the bare spot. As you pull your scope out slightly, you start seeing the posterior labrum. Now, this is where you would observe your reverse Bankart or the Kim's lesion. This can also be observed by putting your scope into the anterior portal. Then, as you move inferiorly into the joint, you come into the inferior recess or the axillary pouch. Now, this is where you would see the Hegel lesions, humeral avulsion of the glenohumeral ligament, or any loose bodies. Now, as you start moving superiorly, you see the bare spot of the humeral head, and a little bit more superiorly, you'll see the attachment of the posterior rotator cuff. This is where you will be able to appreciate the posterior extent of the cuff head. Now, as you're moving more superiorly, you start observing the entire attachment of the rotator cuff from the articular side. And as you sweep your arthroscope more anteriorly, you start seeing the long head of the biceps as it enters into the bicipital groove. This is a point where you could see for any tendonitis or any long head of bicep fraying or tears. You can observe the biceps pulley. And as you sweep your scope from under the long head of biceps, you start seeing the subscapularis tendon. for any subscapularis tears. A little superior to that is your superior glenohumeral ligament. Again, as you slightly withdraw your arthroscope and bring the glenoid into vision, you start seeing the middle glenohumeral ligament, which is a band which runs across your subscapularis tendon. And then this is where you start seeing the anterior labrum, where you would be able to appreciate any labral lesions or any Bankart lesion. And as you again move your scope inferiorly, you start seeing the anterior band of the inferior glenohumeral ligament. Now we've moved into the subacromial space. You can see the undersurface of the acromial and the coracoacromial ligament. And inferiorly, you will see the bursal surface of the rotator cuff. And this is where you will be able to appreciate the cuff tears. So that takes care of our diagnostic round. So we've covered 10 points, 8 within the joint and 2 which were on the bursal side of the joint. Now there are some normal anatomic variants that we need to keep in mind. And especially if you are someone who's starting off new with arthroscopy, you do need to keep this in mind. So imagine your glenoid to be a pear as it's depicted over here. The normal labral variants typically would occur in the antero-superior. So this is the antero-superior portion, or the anterior half of the superior quadrant. This is roughly the equator of the glenoid. So what are the common anatomic variants that you should know and be aware of and not mistake them for any pathology? The first is a sublabral recess. So this is a diagrammatic representation. You can see that the superior labrum seems to be lifted off. However, that may be just a normal anatomic variant. How do you make out? I mean, so once you check it with the probe, so you insert your probe into the recess. Typically, if the gap or that recess does not extend posterior to the long head of the biceps, then you should consider that to be a normal anatomic variant. Something that goes posterior to the biceps tendon would need to be looked at as a pathology. The next is a sublabral foramen. So a sublabral foramen, if you look at the diagram, is an interval or a space that is created between the glenoid margin and the anterior labrum. Here you can see the arthroscopic picture. You can see that there is a space between the glenoid on the left, and this is the labrum. Now, someone may confuse this to be a detached anterior labrum. However, it's not a detached anterior labrum. How do you again differentiate? You will find that the edges of this labrum are smooth, and this tends to extend medially, whereas a labral tear would appear frayed and would extend laterally or superiorly. The next important variant is the Buford complex. The Buford complex is nothing but a thickening of the middle glenohumeral ligament with a deficient anterior labrum. Now, this is again commonly confused to be an anterior labral tear. What you need to see is the direction in which that tissue is going. So your Buford complex typically would start from somewhere near the attachment of the long head of the biceps, but it would head towards the subscapularis tendon, as you can see over here. And you will see that the labrum anteriorly is quite deficient. So be aware of these variants, because if you tend to consider that as a tear and repair that Buford complex, you can create a lot of stiffness. I thank you for your attention, and if there are any questions, I'd like to take that later.
Thanks, Aditya. I think that was very crisp. Any questions
Thank
for
you.
Aditya?
Aditya, as a part of your diagnostic evaluation, do you do any dynamic assessment as well in shoulder? Like,
Yes, so I would be doing a dynamic assessment specifically in an anterior instability. So typically what we see when we once put the shoulder in traction is the humeral head would appear to be either subluxed or dislocated. What we need to assess is, the engagement of the hill sac. And that's when, I would ask an assistant to just lift off the traction weight. So that eases the stress on the shoulder, and then try to put the shoulder into an anterior and a upper position, just to see if that lesion is engaging. So that is one occasion where I would dynamically test the shoulder.
So any other questions for Aditya from the faculty? I see no questions on the YouTube link. I think you're also absolutely crystal clear. And I think you know, your point where you touched upon the normal variance is extremely important, because what happens is, as beginners, when we see a little labral separation from the glenoid, specifically when you're looking at a Buford complex or a subradicular foramen, you'll be very excited to put an anchor there, and you realize that the patient has completely lost his external rotation. So I think with that, I'll start my talk on arthroscopic Bankers repair. I've already shared my screen. Can you all see my screen, and can you all hear me?
Yes, Mihir.
Okay, so I'm Dr. Mihir Patel. I'm professor in orthopedics at the Medical College of Cooper in Mumbai, and I'm going to talk about the shoulder instability, basically about arthroscopic Bankers repair. So we know that shoulder instability basically has been classified by Matson into two types, the Tubbs and Ambry. The Tubbs is typically traumatic, it's unidirectional, and would usually require a Bankers surgery or to tackle the Bankers lesion. Ambry is usually atraumatic, multidirectional, usually bilateral, most of the time managed by rehab, and if a surgical indication is required, usually requires capsular shift procedures. So coming to pathoanatomy of shoulder instability, you have to understand that we have to deal with the labrum, the capsule, and the bone. With respect to the labrum, all of us know about Bankers lesion. In posterior instability, we get a reverse Bankers, and in superior labral tears, are typically called slap tear, and we have Dr. Abhishek talking about that. Coming to the capsule, a lot of capsular laxity will be seen in the atraumatic unstable shoulders, and already Aditya has shown us what a Hagel lesion is. And now, very recently, or in contention and discussion in most of the conferences, is the importance or significance of the bony element in pathoanatomy of shoulder instability, both the glenoid and the humeral. And we have Dr. Sajid who is going to talk in detail about this and help us decide which is the best procedure that we should be selecting for a patient coming with shoulder instability. Do not forget the function of the rotator cuff tear. Usually patients a little elderly after 45, 50, when they come with a shoulder dislocation, they also have rotator cuff tears, and we need to address the glenoid labrum part and also the rotator cuff tears, which these patients usually come with. So anterior instability is the most common unidirectional instability that we see. First episode is usually managed conservatively. A second episode or therein multiple episodes will require a surgical intervention. And Bankers lesion or a tear in the anterior inferior labrum is the essential lesion that is seen in almost 80 to 90% of the patients. So coming to pathology of anterior instability, the first one is tear of the anterior inferior labrum, which is called the Bankers lesion. And also we have to understand that when these patients come back with recurrent dislocations, there is a lot of plastic deformation of the glenohumeral ligaments, and this needs to be taken in care while we are doing surgery, when we are doing not only a labrum repair, but a capsulolabral repair that it is typically called when we do it arthroscopically. The other pathology seen would be a Hill-Sachs lesion. Many times these patients come with a greater tuberosity avulsion fractures. The labral tears can extend superiorly or posteriorly as well. And as I discussed, a little elderly patients will have rotator cuff tears also. So what is the indication of an arthroscopic rotator cuff repair? Number one will be a recurrent anterior dislocator. These patients typically will have very subtle pain, apprehension on abduction external rotation, and an anterior inferior labral tear seen on imaging, typically the MRI finding. Now, the indication for surgery in a first-time dislocator is very controversial and a matter of debate. However, because we do a lot of arthroscopic surgeries and we see a lot of pathologies in patients coming a second and third time, and this is the kind of information that we have to remember before taking decision whether we are going to give surgery to a first-time dislocator, is that 70% of the first-time dislocator are going to dislocate again, specifically, these young, exercise, athletic kind of male population. We also know that arthroscopic Bankart's repair has a very good result. There is always a risk that the patient will come with a bony loss, either on the glenoid, humeral, or both, when it comes with the second or third episode. And multiple dislocations will affect the outcomes of surgeries that we have to offer. And hence, if you ask me personally, a first-time dislocator with these points in view would become a candidate for surgery in my hands. So what are contraindications? So contraindications to a Bankart's arthroscopic repair would be a multidirectional instability, because we know that it is abnormality in the collagen of the capsule. The ligament quality is poor. So no matter whatever repair is going to stretch out, so these patients would be preferably managed by rehab. A significant glenoid and humeral bone loss will be a contraindication for an arthroscopic Bankart's repair. And a Hagel lesion will also be a contraindication because the entire surgical technique will be different. So coming to the surgical options, if you read textbooks, if you read literature, a lot of procedures have been described. But usually, these are the three procedures that we talk about. We talk about the arthroscopic Bankart's repair, we talk about the coracoid transfer, the Latarjet procedure, and a remplissage, okay, in case we have to deal with the Hill-Sachs. So how do we decide? So I'm going to go very fast because I'm not going to take over what Sajid is going to talk. We discuss about glenoid bone loss. Usually 20-25% is significant. We need to shift out after arthroscopic Bankart. If there is an engaging Hill-Sachs and there is a severe Hill-Sachs. So all these things were discussed, okay, before Itoy came with his paper on glenoid tract. So glenoid tract basically is a tract that glenoid makes on the humeral head. So you can see from this picture that the red line is the medial limit of the glenoid tract, and the yellow line, or where the point the rotator cuff inserts in the humerus, is the lateral limit of the glenoid tract. And this is what a normal glenoid would tract with a small Hill-Sachs lesion. So if I just invert the picture, you'll understand that the glenoid in this case completely encompasses the Hill-Sachs lesion. In contrast to the next picture that you see, where the Hill-Sachs is more laterally placed. And if I just invert the image for a better understanding, you see that this Hill-Sachs is more medially placed, and suddenly this glenoid is off track with respect to the Hill-Sachs. So basically, the first image here is an on-track Hill-Sachs lesion, and this will be an off-track Hill-Sachs lesion. So what is important from here is that it is not the depth or length of the Hill-Sachs lesion which is important, but the position of the Hill-Sachs on the humeral head, which is going to be very important when it comes to decision making. Coming then to the glenoid bone loss, again you have to understand that you see this picture. This is the on-track glenoid, which I just discussed in the previous slide. Now, as we come to the next image, just imagine that there is some kind of anterior glenoid bone loss because of recurrent episodes or a bony Bankart where the bone is resolved. And this is the glenoid that we are looking at. If I just invert the image for better understanding, suddenly you will see that the same Hill-Sachs in the same position, but with glenoid bone loss, now becomes off track. So to conclude, you understand that the same Hill-Sachs with a glenoid bone loss, a significant glenoid bone loss, makes the entire Hill-Sachs off track, and a surgical decision making changes. So the amount of glenoid bone loss is also important when it comes to decision making. So I'm going to skip this slide because Sajid is going to talk more about it. In short, the glenoid bone loss decides what kind of procedure you're going to take. Anything less than 20% with a Hill-Sachs on track will be a simple arthroscopic Bankart repair. Anything less than 20% with the off-track Hill-Sachs, I'll add a remplissage. And whenever there is a glenoid bone loss more than 20%, usually it will be a bony procedure in form of a Latarjet. So when I do an arthroscopic Bankart's repair, I operate all these patients in lateral decupitous. Fayaz has very beautifully showed us the positioning. I always use a vacuum beak bag with an axillary pad. The hip and knee are flexed at 90 degrees. The spine is in line, hence a pillow needs to be kept under the skull of the patient. I use about 4 to 5 kgs of balanced traction. So this is a kind of room setup. The patient is in lateral position. The arthroscopic cart is on the anterior side. The anesthetist is on the cephalic side. As a surgeon, I'm standing posterior to the patient's shoulder. The assistant stands on the head end. The scrub nurse is near the leg end. I always use a Mayo's trolley, which basically has all the electrical wires coming from the station cap, and 1 or 2 back trolleys. One of them will have the arthroscopic equipment, and the other would have the general orthopedic equipment. The anesthesia station, you can see, is way anterior. So coming to the portals, the primary posterior portal, as far as described, is typically 2 centimeter distal and 1 centimeter medial that goes to the posterior soft spot and enters into the glenohumeral space. The next portal that you make is the anterior mid-glenoid portal. The external point is going to be immediately lateral to the coracoid. We use the in-to-out technique using an 18-number spinal needle, and internally it exits just proximal or just cephalic to the tendon of the subscapularis. The next portal would be the anterior superior portal. It is 1 centimeter off the anterolateral corner of the acromion. Again, I use the in-to-out technique using an 18-gauge spinal needle, and internally it opens absolutely anterior to the anterior edge of the supraspinatus, typically in the relation to the biceps tendon. So now this is creation of the portals. You can see my 18-gauge spinal needle is entering just superior to the tendon of the subscapularis. My next portal is coming in relation to the biceps tendon. And there is enough space in between the two portals, so there is no crowding of the cannulas. I typically use an 11-number blade. I take a arthrotomy right up to the capsule. I then exchange it with a Weisinger rod. I dilate the portal, and then I introduce a 8.5 cannula in the anterior midglenoid portal and a 5.5 cannula in the anterior superior portal. And you can see that the cannulas are directed or facing the pathology that I'm dealing, that is typically the anterior inferior labral separation from the glenoid. Now, a rasp is used, which enters from the anterior superior portal. So elevator then enters from the anterior superior portal, separating the glenoid separating the labrum from the neck of the glenoid, thus removing all the adhesions. And the target or the aim of this procedure is to see the fibers of the subscapularis. That basically tells us the end point of the separation of the labrum from the glenoid. Also, the end point is where the labrum automatically floats up to the surface of the glenoid. So that means you've removed all adhesions of the labrum from the neck of the glenoid. Then you put a rasp. Okay, you rub the rasp against the glenoid neck, thus opening up bleeding points. I also use an arthroscopic shaver and a burr to freshen the neck of the glenoid and also the edge of the glenoid where actually the labrum is going to be repaired. So that's my arthroscopic burr going in. So my next step is anchor insertion. So multiple anchors are available today. My choice of anchor today is an all suture anchor, which are usually double loaded. These come with sleeves, as you can see, and they need to be drilled. The anchors are then, packed into the glenoid, and typically they have 4 sutures, and then you can use it to repair the labrum back to the glenoid. You can see the sleeve comes in from the mid-glenoid portal. It gives a nice angle of attack of at least 70 degrees so that you don't skive off the glenoid. And the drilling is done on the face of the glenoid and not on the edge. This video is a little old video when I'm using a peak anchor. So the anchor is inserted typically at about 5 o'clock or 5:30 o'clock position, so that when I repair the 6 o'clock labrum to this 5 o'clock, I'm creating an inferior to superior shift. Thus, I'm removing the redundancy of the capsule created by the multiple dislocations. So then 2 sutures, one of the sutures is shifted into the parking portal, typically the anterior superior portal. And then we come. So I use a suture hook, which is usually about 8 to 10 millimeter in size. So I pass my suture hook distal inferior from the point of insertion of the anchor. So automatically when I repair the labrum, I'm getting a superior shift about almost 7 to 8 mm, which removes the redundancy of the inferior glenohumeral ligament and recreates the inferior hammock, which is very important to prevent a further dislocation. So I use a retrograde technique. A number 1 ethylon or a black suture or a polyester suture is passed through the suture passer, which is retrieved from the other portal. This passing suture is then used to shuttle the fiber, and finally a knot is passed. Very important that the post should be the suture which is going through the tissue, hence your knot bunch is away from the glenoid. And you see, as I tighten knot, the entire labrum and the capsule is plicated and it comes against the glenoid, thus creating the so-called bony bump. We repeat the same procedure. We put our anchor at about 5 o'clock position. The next anchor will be at about 4:30 o'clock position. And the third anchor would be at around 3 o'clock position. The number of anchors you will again decide will depend upon the size of the labrum that is torn, so that effectively you're repairing the entire labrum back to the glenoid. Avoid putting anchors in the anterior superior quadrant, because most of the normal variants of the labrum that Aditya described are seen in the anterior superior quadrant. And the more you're going to repair the anterior superior quadrant, the more loss of external rotation that you are going to get. Also, you have to understand that in anterior instability, it is not the anterior superior labrum which is pathological. It is the inferior glenohumeral ligament, which basically attaches at the anterior inferior part of the glenoid. Now, this patient also had a Hill-Sachs, so I decided to go ahead with a remplissage. Now, we can see that I'm freshening the humeral bone loss that we can see in the posterolateral humor with a radiofrequency device. You can also use a shaver or a burr, so that all the soft tissue is removed. If I'm seeing from the anterior superior portal, and my working instruments are coming from the posterior portal, you can see all the fibrous tissue is now removed. You can either use a single anchor or you can use two anchors, again, depending upon the size of your Hill-Sachs defect. So that's freshening the Hill-Sachs. So in this case, I've used a single double-loaded anchor, which is introduced into the Hill-Sachs defect from the posterior portal. You can see these 4 sutures exiting the posterior portal. Now, these sutures are retrieved through the posterior capsule. You can see this there. So I'm using a direct device, which is called the bird beak, which takes multiple punctures through the posterior capsule and takes the sutures back. And then when I tighten these sutures and create the knot, what happens is the entire posterior capsule goes into the Hill-Sachs defect, thus exteriorizing the Hill-Sachs. So this is remplissage, which basically means to fill. That's the meaning of the word remplissage. So that's the completed product where I finished my anterior labrum repair there. And then I've done a remplissage behind, and we see that the humerus is well centralized on the glenoid. So coming to the rehab protocol, these patients, all of them go into an abduction brace. I want them to be in neutral rotation. Immediately they start pendulum and isometric deltoid and passive forward elevation. By about 2nd month, active sets are started. By about 6 weeks, I start external rotation stretches, and these patients can resume their sporting activity by about 6 months' time. So I thank you for your attention. Fayaz, any questions?
May I ask, Abhishek?
Yes, Abhishek, go ahead, please.
Yeah, hi. So basically, when there are, say, subclinical bone loss, and you're doing this Bankars and you're freshening the Bankars, your preparation of the bed, do you still use your shaver? Because if you're using it, then how do you make sure that you don't, overdo it,
Yeah. So Abhishek, very, very relevant, very practical point. So I will use the shaver in the reverse direction. I would in fact use a burr in the reverse direction. So my target is just remove the fibrosis. I don't, tend to remove too much bone. But you have to understand that we need fresh bleeding bone, like any fracture surgery or non-union surgery,
Right.
the so-called paprika sign. So we're not trying to remove too much bone. We just remove enough soft tissue so that we open up the bleeding channels, which helps us in healing. So I did not discuss too much about the bone loss because I know Sajid has a fantastic talk coming up to explain us what is the latest that we follow. So this was I'll use a radio frequency device and then I'll use a burr in a reverse direction. So we don't have bone loss, but at the same time we're removing soft tissue.
Right.
So Mihir, while taking the inferior most bite, it's very difficult to go right from superior edge and then take the capsule from there while doing an anterior-inferior bite, at 5 o'clock position or beyond that. So any tips for that?
Yeah. So again, a very practical discussion this is. So number one, I would usually ask my assistant to give me some kind of lateral traction. Okay, so a lot of these traction devices have a lateral traction device. I usually use the spider device, which has something which just picks up the humerus up and gives a nice vision of the inferior axillary pouch, and then you can get a very good passage. The second thing that you can do is that instead of using the anterior portal for passage, your scope is always in the superior portal, so you're seeing from the top. You can use your suture passing device from the posterior portal. Okay, so the posterior portal can take a bite, not from 5 o'clock, but actually from 6 o'clock. And then when you repair that to your glenoid anchor, which is at about 5:30 o'clock, immediately gives you a nice superior shift of the capsule, thus removing, as I said, the redundancy of the capsule and you are recreating the inferior hammock. Now, the third point is you may not even use the retrograde passing devices. Now, you have these anterograde passing devices of the labral scorpions, okay, where you can directly take the anchor suture, take a nice bite, usually about 8 to 10 mm, and makes your life very easy.
Yeah.
So in the meantime, Abhishek, what I would suggest you can start sharing your
And
screen.
just, yeah.
So Fayaz, anything different that you would do, or
Is my
anything
screen visible?
more that you would do to enhance your healing process, or
I think just freshening up the edges is good. I mean, I've never used these PRPs and all that stuff. I mean, honestly speaking, I've never used it. Maybe people might have got better results, but I don't have any experience with that. But freshening good bone is the key to it. So far, so good. We've not got any issues with that.
So I would just ask all the faculty members here, um, with respect to the position of the anchors. Okay, so it's typically told that we put the anchors on the face of the glenoid. Any of our faculty members do it a little differently. Sajid, you want to add to this?
I think the 5 o'clock and the 6 o'clock anchor, if you get it on the face of the glenoid, always the final appearance of the repair looks nice. And like you already described so well, it's so important to get that anterior inferior craniohumeral bite. And if you do get that bite proper and put it on the face of the glenoid, I think that itself does majority of the Bankart work.
Right.
The remaining anchors, I'm not so keen on putting it right on the face of the glenoid. I would even go on the edge of the glenoid, because at the end of the repair, the glenoid articular surface seems to be covered with capsule, and that I do not really like. And I'd really like to see the middle third of the glenoid exposed rather. So for me, the most important anchor, the 5 or the 6 o'clock anchor, whichever one prefers, would mostly go slightly on the face.
Okay,
For
so
that
a very
piece,
quick question to all the faculty members. Choice of anchor. So let's start with Abhishek. What would be your anchor to go for arthroscopic Bankart repair?
So I think it's a very tough question, because every anchor has its pros and cons, and you have to know what are the pros and cons of every anchor. And most of the time nowadays, at this point of time, I'm using knotless kind of all suture anchors,
Yeah.
but they have their own set of problems. You can use bio anchors, you can use your peak anchors, all of them are fine. Just one thing, never use titanium anchors for Bankarts. That is the one thing
Okay.
that I would not use at all in any case.
Okay, so Abhishek's choice is all suture, not less. Sajid, what's your choice? So you're doing a Bankarts tomorrow morning. Which anchor do you have ready?
I somehow started liking the all suture anchors, but I'm also closely observing the incidence of subchondral cyst, which many people are reporting with the use of these anchors. I'm not sure how much of experience I have got to even say about the cyst formation, because these anchors are very fairly new. I think we really need to observe, but it makes very small holes on the face of the glenoid. So taking off less articular cartilage. The insertion process and the application itself is so minimally invasive that I think these anchors are the way to go, at least currently. And peak anchors would be my second option, which would always be there if in case this does come out or we are looking at a very soft bone. But additionally, I also keep some metal anchors for the remplissage, because most often this cancellous bone tricks me and the anchors just comes out after application. So a metal anchor, a peak anchor, and a sol switch anchor, everything will be there on standby.
Yeah, so Sajid has all the company people standing behind him. Fayaz, coming to you. Okay,
Yeah,
so we
initially when these all fancy anchors were not available, that's way back 15 years when we all started together. So that time I used to use these metal anchors, but those disasters, as Abhishek rightly said. So I have stopped using metal anchors altogether. I use either a biocomposite anchor, which is like to be pushed inside and locked rather than having screwing action. Or now I've just exclusively started with all suture ankles, because the hole is so small, just as Sajir said. So only small trick that I am trying to, I mean, just we missed in the last discussion, is that when you're tying the knot, the first, I always use this antegrade suture passing device from the anterior portal and take the most inferior bite, so that, as Sajir said, that once you have that anchor placed and that capsular shift proper, then your majority of the work is done, irrespective of, The last anchors, what happens is that when you're tying the knot, I always use this knot to be tied rather than, just hold on. Yeah. So I always use this knot to be tied with my hand so that my assistant from the posterior portal pulls the capsule superiorly so that my knot goes proper. Otherwise, what happens is that you've taken the bite properly, your anchor is in proper place, but the capsule is pushed down because you're pushing the knot below, if you can understand what I'm trying to say. So if before tying the knot properly, if the capsule is pulled up by the assistant and then you take the knot, the capsular safety is very well, and that banker would bankart repair will not fail.
If I can make a point regarding this subchondral cyst that Sajir said.
Yeah, go ahead, we can listen.
Yeah. So basically, the possible explanation for that is the hydrostatic pressure that is there inside the joint. And it is very important that if you are using these anchors, okay, you cannot get away by, whatever you do, you may have this cyst formation, but you have to give a good compression, because if your bite is loose or if your labral is not compressed properly, then the chances are more. So you have to be very careful about using these anchors. And even though in all suture anchors, the pilot holes are small, but still inside the bone, you have a big lump formation. That is the way it stops pull out. And that is why, putting in too many anchors again is a problem, because you can't see what is going on inside. You can only see the face. And that is where the problem starts.
Right. So is there any specific sequence, like first we insert the hill sack anchors and then we start with the bankart, or any recommended sequence, or we can do first bankart and then go?
So basically,
Well-
for what I do, it is mainly once you have decided that you are going to do a remplissage, you put in the remplissage anchors and you take the bites. Nowadays, more often than not, I'm using a double pulley technique. So you don't have to take the bites. You just put the anchors and keep it in situ. And then you finish off the bank cards completely. Once that is done, then you can come back and do the remplissage. So you can complete that. Any other ways, Dr. Fayaz, Dr. Sajir? Any other thing or any other sequence that you follow?
I prefer to do is because in a bankart repair, the bankart repair is the main part of the surgery is what I believe. And so what I would do is first put in the lowermost anchor onto the glenoid, finish off that bite, and then I'm like happy that okay, the main work is done. Then go in for the remplissage and then finish off with maybe the second, or if required, the third anchor for the bankart. So the bankart first, then the 6 o'clock first, the remplissage next, and then the remaining bankart.
One common thing has happened twice with me is that whenever after putting the hill sack, the titanium, normally use a titanium anchor for the hill sack. So when I insert the titanium anchor and whenever I'm trying to tighten, couple of times the knot doesn't slide up to the hill sack. So I don't know. I never understood the reason. It gets locked. Means I can clearly feel that it's not going inside, but when I am checking afterwards, just going through the scope and checking, I've seen that there's a slight gap between the hill sacks and the cuff in one of the anchors, in one of the bites. So my few bites are good, but whenever I usually double loaded, so double loaded, if I'm using two anchors, I see that one or two knots are not sliding up to the bone. So is there any particular reason, or does
So
it
there
happen?
is the question of suture management basically. So when you're sliding one knot, keep the other ones separate, and then you do it. And you have to visualize that the knot goes. Otherwise, it is just those knots, and it is not the healing of the capsule to the bone. So that you need to
Right.
remember. So it's all about suture
Right.
management. In fact, honestly
Right.
speaking, in the initial days, when I had just, remplissage had just come and Mihir had already started doing it, I was not doing it. So Mihir had specially come to teach me how remplissage is done. I would thank him today also for that. It's
Okay.
more than 1.5 decade, but still I would thank him for that.
Great. So I think Abhishek, you can start your talk on slab repair.
Can you see
You
my
already
slide?
shared the screen.
Yeah, great. So slap repair, whenever we talk about shoulder arthroscopy, more often than not, we talk about Bankards, we talk about rotator cuff, and that are the topics that are routinely discussed. Slap repair is something that is often ignored, and there's a lot of problem because we really don't know how to go ahead. In spite of so much of research and time spent on slap, we still have a lot of confusion regarding how to proceed with the slap. So let me try to bring a few things here on notice. I hope that the slide is playing. So let me start from what is SLAP. Basically, SLAP lesion is an acronym for superior labral tear. So it's a labrum and the biceps complex that is sheared off from the superior glenoid. And it's a fibrocartilaginous rim attached around the margin of the glenoid, so which is peeled off, leading to the SLAP lesion. This was first described in way back in 1985, primarily seen in overhead athletes. And in 1990, this term was coined by Snyder, who also gave the initial classification, which we have been using for, say, over a couple of decades. We always think that biceps, the long head of biceps, is a vestigial thing, and it can be sacrificed, and there is no relevance to that. However, you should understand that in young people, especially athletes, and also in patients who need overhead activities, it is required for increased stability to the glenohumeral joint. It causes humeral depression and gives counter force for the short head of the biceps, prevents proximal humeral migration, and the increased biceps tension significantly reduces anterior displacement of humerus at 60 to 90 degrees of external rotation. So these are the four types of tears that are commonly noticed and discussed. One is just in fraying or a minor detachment. You can't go underneath the slap. That is type 1. Type 2 is the most common. It is seen in 55% of the patients, and more often than not, you'll see in all the MRI reports that you get that they will mention about a type 2 slap lesion. Type 2 is a detachment of the superior labrum and the biceps from the glenoid rim. Then you come to type 3, which is a bucket handle tear, in which like a bucket handle tear in the meniscus, you'll see a rim of superior labrum, but the biceps is still attached. And in type 4, the biceps also tears along with the superior labrum. Okay, so in view of time, I'll skip this. So recently there have been a lot of other varieties, up to 10 varieties that have been described for slap lesions, and they are a combination of usually a type 2 slap along with either a posterior extension or unstable flap or a MGHL injury or a Bankard's lesion. So there are multiple variants that are there on combinations, and the classification has been extended. Causes are two. One is acute trauma, and second, and the most common, is repetitive overhead sports, like throwing and weightlifters and all those patients who require overhead activities with violent force can lead to slap tears. And the other part is wearing down of the labrum that can happen slowly over the time. And these are the second group of patients who would require something else than the slap repair. We'll discuss that in due course. So traumatic events, as I said, are one of the most important reasons that you see in Indian patients, apart from sports. Symptoms are mainly sensation of locking, popping, catching, grinding. Pain is the most common symptom. They'll come to you with persistent pain, especially when they are doing overhead activities, lifting objects, taking up bags, and all these things. So whenever they require, force that has to be transferred from, overhead activities. Decreased shoulder strength and range of motion can also be present along with this particular thing. Typically described in pictures where they feel like a dead arm after doing the pitching, but that is not seen in our patients. Diagnosis, clinical diagnosis, I won't go on that because I personally do a O'Brien's test, but then we are not very sure about how to actually diagnose it clinically. You do an MRI, and on MRI, you can see a fluid lesion between the superior labrum and the superior glenoid. Type 1, the management is fairly simple. We actually go with physiotherapy, activity modification, and anti-inflammatory medications. However, the problem is in type 2. it is very controversial, it is very challenging, and lot of times you should actually offer conservative treatment to the patient until the patient is not relieving for a significant amount of time. Treatment actually depends on multiple factors, depends on the patient age, activity level, pathology, duration since trauma. So multiple reasons we would have to assess. I'll show you an algorithm on which how you can decide the treatment. And irrespective of all the possible treatment options, the results are mixed and the clear treatment algorithm has yet to be decided. So type 3 onwards, more often than not, they will have a lot of symptoms and will be, most likely will have to intervene at some point of time. So with that, let me just come to the main thing that we are discussing now, the slap repair technique. So I'll give you two types of videos. One is a knotted and one is a knotless. The video is in fast forward just to save time. So here what you do is actually you start refreshing the superior labral lesion, and unless the labrum is peeled off from the glenoid, this you cannot call it as a slap tear, and you should not be repairing such kind of lesions. Once you are confirmed that, you go inside and debride the superior. So you have to prepare the bed for the healing. So debride the superior labrum, and also, so this is how you do it. So you can see the bare area where the labrum has to be repaired. Usually you require one or two anchors, more likely two anchors, because one is under the biceps and one is posteriorly. You have to actually look for the lesion extension, because a lot of times you'll put in one anchor and you feel that yeah, this is good enough, but you should actually go behind and look for posterior anchor as well. So now you are putting the anchor on the superior surface of the glenoid, and typically what I do is, take one bite each from either side of biceps. So one tiger is taken from the posterior side, and then I can put a knot to it. So that will fix the biceps from one side. Okay, fine. And then you go around the biceps, take another bite to the superior labrum, and repeat the same step. Okay, so this is the other side of the biceps. And then you can put a knot onto it. And once that is done, you put another anchor, which is usually a single loaded anchor on the posterior side. It has been widely known that all these knots can cause a lot of bursitis and irritation to the patient, and that is why in this scenario I would prefer to use a knotless anchor. So this is a posterior anchor. This is the second anchor that you put in. You can also come from the opposite side, see from the front in case there is any problem in visualization, because this is too close to the scope, the posterior end. So take in a bite and then you tie a knot. And this is how a stable repair looks like. With that, let's go to the second one, a knotless technique. Again, you have to clean and debride the bed and prepare the bed for healing. See that you can peel off the superior labrum. So enter first. So either you can take bites in this particular case and then put in a pilot hole, or you can actually do a pilot hole first, because you don't want to drill and damage the fiber wires. So you can prepare the area for repair, put in a pilot hole, and then go in with your bites. And there are multiple ways with which you can do the bites. Again, you can do with mainly, it's with the lasso from top to bottom, or you can use a bird beak. So here the pilot hole is done. so that you are not drilling after the bites are taken. Let me just fast forward this. Okay, so the bite is taken, and then you, in this particular scenario, you can use a mattress kind of a technique so that you get a good purchase onto the labrum. So you take one end of the loop outside, and then without withdrawing the lasso completely, you can take a loop from it. So you have two threads coming out, forming a loop around the superior labrum. So this is, okay. These threads are then loaded through the anchor. So once you pass in the anchor, you don't have anything on the superior surface here. And you will see it very soon what happens after you punch in the anchor. So once the anchor is done, you have a loop that is going up and coming down again and through the anchor outside. And that's it. This is done. This is the construct after you finish the knotless repair. So take-home message is that the sign and symptoms are not often conclusive. MRI is the most sensitive test for diagnosis. Type 1 is pretty clear. Type 2 is very controversial, and you will always have difference of opinion. Adequate conservative trial should always be given before offering any kind of intervention to the patient. Result of prognosis, I have seen that it's very unpredictable, and you should consider alternate procedures whenever possible, like biceps tenodesis, which is inside the groove, or even you can consider subpectoral tenodesis whenever possible, especially in middle-aged people and low-demand people. And in elderly people, you can always do a biceps tenotomy and the slab debridement. Thank you. Any questions?
Very nice video, Abhishek.
Anything? Thanks. Anything different that you, Sajir or Fayaz?
No, personally, I don't do a lot of slab repairs. Only if it's a part of a global labral repair, the slab
Right.
is addressed.
So I think,
But I would like to really carefully look at MRIs to find those bucket handle type of slab tears.
true.
Because I feel those are really symptomatic, and just excising them itself also sometimes works very
Yeah,
well.
so bucket handle, especially type 3, you just have to excise the bucket handle. That's it.
Yeah, so
And then it will stop the symptoms.
I try to carefully look at MRIs to find these buckets. Maybe I've seen in a one or two where there was a real
So do you
nice
see them on
bucket.
the console, or you are able to find them on the MRI films?
I saw them on the MRI films probably once or twice. But like you said, probably they appear better if you have thin section MRIs and you keep looking at scrolls. But I think I still am learning how to pick up these buckets.
I think the bottom line in
Abhishek,
slab is that,
Abhishek, could you unshare your screen so we can, start
yes,
sharing my screen?
I'll do that.
In the meantime, we can have the discussion continue.
Yes, done.
No, the most important point that Abhishek shared, which is very valid, is this knots on the superior labrum repair always creates a lot of irritation, inflammation, and the results of them, they have throwing pain before surgery, they have throwing pain after surgery, so they are confused whether it's the repair or the knots. They end up in some shots just to reduce the inflammation, and eventually they do get results, but the knotless anchors is probably my way forward, if at all we consider a slab repair, isolated slab repair.
Yeah, I
What do you
completely.
say? Yeah.
Yes.
Sir, in old age, like after 50s, rotator cuff tear, it's very common finding to have a slap tear associated. In MRI, it's always visible that slap tear, evidence of slap tear visible on MRI. So, do you address that while repairing the rotator cuff at the same time, like a tenotomy or some other procedure, but tenodesis?
So if you don't treat the superior labral complex when you're, because that is the pain generating factor. So it is always better that you treat it along with the cuff repairs. And in these elderly degenerative kind of scenarios, it is better that you do a slab debridement and a tenotomy if the patient is low demand,
Okay.
or else you can consider some kind of internal in the groove or subpectoral tenodesis.
Okay.
That is what I would look at. But always address the biceps labrum complex, because the cuff is giving you functional issue, but biceps is giving you pain. And more often than not, the patients are coming you for pain. If you don't relieve them of pain, then they will feel that
Mhm.
the results are suboptimal. So you should always treat
Okay.
the biceps labrum complex.
Right.
Okay, sir. Mhm.
So if we don't have questions, I think I'll start the next talk on arthroscopic cuff repair.
Yeah,
Yes.
you can
Go
see
ahead.
your presentation.
Okay, so you can see my screen.
Yes.
Okay, so coming to the rotator cuff repair principles, the main objective is to closure of the cuff defect. Thus, we are minimizing the superior escape of the humerus. We need to eliminate impingement so that there is no future tears because of the acromion hitting the greater tuberosity. At the same time, and most important, we preserve the origin of the deltoid and prevent adhesions post-operatively. We can do this rotator cuff repair either open or arthroscopic. And whatever be the technique, the goal of the cuff repair is going to optimize the biology so that we get good healing. At time zero, we have the highest fixation strength so that we can mobilize the patient fast. Minimize gap formation. So again, good anchors, good suture kind of repair, and maintain the stability while the patient is under rehab immediate post-op. So depending upon the type of tear you have, whether it is full thickness or partial thickness, you can do either a single row or a double repair. And in a partial articularis sided tear, you can do a transtendon repair, or on a bursal sided tear, you can do a bursal sided repair. So the advantage is, I feel, in an arthroscopic technique is obviously we are seeing everything magnified under fantastic illumination. You can characterize a tear, you can mobilize, you can assess what kind of tear pattern it is. And I think one of the most important advantages of using the arthroscopic technique is the assessment of the glenohumeral joint, because many times a lot of pathologies in cuff tear patients are in the glenohumeral joint also, namely the adhesive capsulitis, which requires a capsular release. A lot of times labral pathologies are there, like, we just discussed the superior labral tears, synovitis, and even involvement of the bicep tendon. And also, I feel the arthroscopic technique uh, minimizes deltoid injury. In fact, I feel it is almost zero when you do it arthroscopically. Everything comes with a disadvantage. Yes, it has a steep learning curve. Equipments are expensive. Anchors are more expensive. And in case there is poor bone quality, and if you're a beginner, I think you should not shy away from converting into an open procedure and abandoning your arthroscopic procedure. So again, I do all my arthroscopics in lateral positions. My first portal will be to enter the glenohumeral joint, because we need to see the glenohumeral pathology. So it will be the primary posterior portal. Again, 2 centimeters distal, 1 centimeter. Effectively, it's through the soft spot. You put your thumb on it and you feel the spot with the index finger of the coracoid. We use the anterior mid-glenoid portal and the anterior superior portal, and we finish the entire glenohumeral diagnostic arthroscopy and take care of all the pathologies in the glenohumeral joint. Then coming to the subacromial portals, the lateral portal, which is in line with the posterior AC joint and about 3 centimeters off the edge of the acromion. So this position is selected because most of the cuff tears are in the superior or posterior superior cuff. And using this portal, you can address it very well. The other portal is going to be the posterolateral portal. This is going to be a viewing portal. Again, it's about 2 centimeters off the posterolateral corner. But practically speaking, I usually take it midway between my posterior and my lateral portal. So again, first is going to be a glenohumeral arthroscopy. You look at the bicep tendon, you look at the rotator cuff, and here you can see, as I turn my scope superiorly, I can see a full thickness supraspinatus tear. Also, I'm assessing the amount of greater tuberosity which is uncovered, because this gives you the amount of tear. So if there is a partial tear, depending upon the amount of the tuberosity is uncovered, you can decide whether you are probably going to conserve this tear or you're going to fix it transtendon or from the dorsal side. I always mark my tear with a number 1 athlon. So a spinal needle comes from the subacromial space, delivering a number 1 athlon into the joint, which I secure in the anterior portal. The reason I do this is, you'll see in the next slide, that when we go into the subacromial space, many times it's not as clear that you see in this video. It's the whole subacromial space is filled with the bursa, and it's sometimes very difficult to identify where your tear is. So this black suture, okay, or your blue suture if you're using PDS, helps you where the tear is. We then create a lateral portal. We use a shaver radio frequency device alternatively to clear all these bursal curtains. Typically the posterior curtain, which is usually very vascular, even the lateral curtain, because we're going to go way laterally below the greater tuberosity to put a lateral row anchors in case you're doing a double row repair. You can now see very clearly how the entire cuff tear starts coming into your direct vision. We are now assessing the cuff tear with a probe coming from the lateral portal. So what we do is we also remove any spurs from the undersurface of acromion, which is basically called an acromioplasty. The target or the aim of this is, typically converting the type 3 or type 1 or type 2 acromion to a type 1, okay, as per the needs of the theory. So we remove any bony spurs which can cause or damage your repair. And also it is believed that when you do an acromioplasty, you have these stem cells or bleeding points coming, which enhance your healing. Once this is done, we shift our scope to a posterolateral portal, which gives you a nice bird's eye view of the entire cuff tear. And this vision is very similar to what you do when you do open surgery. So basically, I tell all my residents, all my fellows, that when I do an arthroscopic procedure, I'm not doing anything differently. It's only the way I'm looking at the tear if it is changed. Otherwise, all the principles, all the repair techniques, and all the theory that we've learned and we've done in our open procedures follow true when we're doing an arthroscopic cuff repair. Following this, the most important step for me is the tuberosity preparation, because this is where your entire cuff is going to stick back. Okay, you need to spend a lot of time. I use a radio frequency to remove all the rotator cuff footprint which is there on the tuberosity. I will use a shaver and a burr alternatively to remove the sclerotic bone. We in short decorticate the tuberosity so that we get good bleeding point, or we so-called paprika sign, the pinpoint bleeding, because this is going to get you all the bleeding, your blood clot, your stem cells, which is going to enhance your healing of your rotator cuff tear. And you need to work very hard in these cases because most of these patients of cuff are elderly, usually diabetic, hypothyroid. So you need to do everything that you can do to get in all the biology which enhances your healing. At this stage, now you start planning your repair. So depending whether it's a crescent tear, L-shaped tear, you need to use your grasper or suture retriever and just pull the anterior and the posterior leaves of the cuff to identify whether it's an L or a reverse L shape. And this is when you decide where you're going to put your anchors, how you're going to do the super management, or whether you're going to do any possible margin convergence or not. So this step becomes very important. At this stage, now you decide whether you're going to do a single row repair or you're going to do a double row repair. So what we mean by a single row repair is where the anchor is put only in one line. So basically, you can either have the anchor going where the yellow arrow is just at the edge of the cartilage, or you can have in the green where it's at the top of the tuberosity, or over the top or over the edge of the greater tuberosity. So this is a single repair. And in contrast, what we do in a double row repair is we put one anchor in the near medial edge, very close to the cartilage, and one anchor over the top of the greater tuberosity. So what we are trying to do is we are trying to cover the entire footprint. Okay, it is said theoretically that it reduces the cyclical displacement, reduces gap tension, and gives very high biomechanical strength. However, it increases your cost, takes time when you start, and obviously, if you're going to try to pull the cuff, over the edge, you're repairing it in a very high tensile strength, which you don't want to do. So you have to understand that either a single row or a double row can be performed for any tear size. So it's going to be your choice, the amount of mobilization of the rotator cuff you can do. But remember, most important is whatever repair you do, a single row or a double row, it should be done without any undue tension, because any tension in your repair is going to fail. So now coming to medial row anchor insertion. So you finished your glenohumeral scopy, you finish your subacromial decompression, and now it's time you're going to put your medial row anchor. So you have to say this is the dead man's angle. The anchor is inserted typically 90 degrees to the long axis of the arm. So that's the insertion angle. And the points of insertion will be just off the lateral edge of the acromion. For an anterior anchor, just the anterior to the lateral portal. And for a posterior anchor, posterior to the lateral portal. So you can see the blue and the brown dots. That's going to be a portal from which your anchors are going to be inserted percutaneously at an almost 90-degree dead man's angle. Now, what do you want to capture? You have to understand that we are working in a place where the bone is very osteopenic. Most of these patients are osteoporotic women. So you want to capture or you want to put anchors in the best, strongest bone. So the best bone that you have is subchondral bone. And hence I believe that the medial row anchor gets very good hold. You pass it into the subchondral bone. The greater tuberosity anchor is, the bone quality is very poor and the anchors usually don't have hold. So your lateral row anchor, then you have a better hold than your greater tuberosity. And that is for me, the medial row anchor is going to be just at the articular cartilage. I never put these yellow anchors. I put the anchor over the top, which is the lateral row, knotless anchors, thus converting it into a double row kind of repair. So this is a medial row anchor going. You see the angle of attack, very perpendicular. In case you are using a peak anchor or bio anchor, you need to produce a pilot hole, probably even tap it. And you'll realize when I remove this tap, that the hole is absolutely touching the articular cartilage. So this is a medial row anchor. You then insert the anchor. I typically like using triple loaded anchors in most of my double row rotator cuff repairs. So this is a peak anchor going in. It usually has 3 sutures, so we have 6 tails coming out. Once this is done, then I secure my suture, which I'm going to pass to the cuff to the lateral working portal, and the remaining sutures are going to be parked in the posterior portal. I always use antegrade suture passing devices. And because I'm using a triple loaded anchor, I need to pass these sutures through the tone cuff at the muscle tendon junction. And I'm going to take one suture of each anchor, use my antegrade suture passing devices, and pass it through the cuff, ensuring that these sutures don't pass into the bicep tendon. So that is first of my suture which is passed. And as my suture is passed, I pass them into the anterior portal. I take the second suture, and sequentially you will see I'll pass all the 6 sutures through the cuff, thus distributing all the 6 sutures along the entire cuff tear pattern. Because this is a crescent tear, I'm going to use the sutures equally, 3 anterior leaf and 3 posterior leaf. I then I'm going to start taking each pair and I'm going to start knotting the medial row. So again, a lot of discussion about whether we need to knot a medial row or not. I always knot my medial row. So you're seeing my medial row is being knotted. So I'm going to get 3 knots because it is a triple loaded anchor. So that's my second pair being knotted. And then finally, I'm going to use my white suture. I'm going to knot it. So my all 6 are knotted back, and I'm going to get 3 knots, thus completing my medial row repair. All the 6 sutures are then passed into the lateral working portal, loaded into a knotless anchor. A pilot hole can be made over the greater tuberosity. Nowadays, we get anchors with these metal tips, so they are self-punch anchors. You know, it saves one step. So this was the time when I would use these pointers. It makes the pilot hole. All the 6 sutures are passed through the eye of this eyelet, which is a peak eyelet. It is hammered into the bone, thus, taking the sutures off the medial row anchor, creating a suture bridge kind of configuration. And then you fix the anchor, remove the slack from each and every anchor. As you can see, you don't want to tighten it too much because you want to have a tension-free kind of repair. And then you hammer the anchor and you screw it. So you get a kind of interference fit of the sutures against the tuberosity bone, thus completing your lateral row repair. So that's your completed product. You can see a suture bridge kind of configuration, compressing the cuff against the prepared greater tuberosity. You can already see the bleeding points coming in, and that's a very good sign because you know the vascularity is going to help healing of the rotator cuff. So basically, this is the kind of cuff tear we started with. This is what would look when you do a single row repair and a double row repair, giving you a suture bridge or a transosseous kind of repair. So coming to footprint coverage, a single row repair gives you a footprint coverage of around 50%. A transosseous repair, okay, when we used to use the open technique, gives you about 80-85%, and a double row repair nearly approaches about 95% of footprint coverage. So this is a medial single row repair, and this is a lateral anchor single row repair. So what happens when these patients start mobilizing? Okay, there is gap formation near the edge when you're using the lateral, and that is something like an iatrogenic cluster kind of tear. And that is why people started shifting to double row repair or a transosseous equivalent, which we were using all these years when we did open technique. And that is exactly what we do when we do double row repair. We put a medial anchor, we put a lateral anchor, and we have the entire footprint of the rotator cuff pressed against the greater tuberosity. So coming to the rehab program, all these patients go again into an abduction splint. I start passive forward elevation, external rotation almost immediately. And I'll keep them passive for about 10 to 12 weeks. I'll start active assisted, wall ladder, isometric deltoid. And usually we've seen that these patients start, getting reasonable, good pain-free function after about 12 weeks. And then slowly they can get back to their pre-injury kind of status. So to conclude, I think rotator cuff repair arthroscopy is the future. Yes, it has a learning curve like any new technique, but remember the principles are absolutely same. There is no tear indication of a double or single row. Most important is you need to mobilize your footprint and you need to have a repair which is without any tension. And a supervised rehab program is absolutely essential to guarantee success. So with that, thank you. I'll now stop sharing.
I think in view of time limitations, we can straight away go to the next topic by Sajir Usman. Should that be good, Mir?
Yeah, I think we should do that because we already crossed the
Offshore
10
time.
o'clock zone.
Okay, since we have already reached the end of the, can you hear me? Am I audible? One
Yes,
second.
Sajid.
Yes, yes, you are.
Okay, so since I'll make it quick, the topic that I have to deal with, whether to go ahead with a soft tissue procedure or to go ahead with a bony procedure when we are dealing with shoulder instability, anterior inferior instability. And to regarding this point, there was a discussion 25 years back with the greats of shoulder arthroscopy, Stephen Buckett and Jody Beer, who sat together after an AOS meeting in the year 2000, where they started seeing the shoulder instability repairs failing, and they started asking questions, and they came up with, sorry? I'm having an interference actually. Am I
No,
audible?
no, your voice is echoing. Now you're fine.
Is it okay now?
Yeah.
No, I think it was because of me. I logged in through my mobile instead of this thing. So probably that was the reason.
Okay, so Stephen Buckett and Jody Beer asked the question, why do the soft tissue procedures fail? And they came up with this article together as a collaborative effort which was published in Arthroscopy. And the primary reason that they pointed out is the inverted pear-shaped glenoid, which essentially means the anterior inferior glenoid is deficient. And like Aditya had pointed out, the glenoid should be pear-shaped. But when it is inverted pear and the inferior portion of the glenoid is deficient, is what's called an inverted pear-shaped glenoid. And this is what they pointed out in the article 25 years back. And if we have to assess this in our cases, we have to understand that this is the face of the glenoid. And if we take a look at it, a portion of the glenoid, especially in the anterior inferior quadrant, can get deficient. And this is what's called an inverted pear appearance. And the reason for this essentially is, as a part of the primary dislocation itself, a piece of bone can come off from the anterior inferior aspect, which is called a bony Bankart, or as a part of recurrent dislocation, when because of the repeated attrition, the anterior inferior bone can get deficient. So these are the two theories as to why bone deficiencies happen on the glenoid. And how do we assess this? If we get an MRI or a CT, we can do the different methods of testing and checking the glenoid bone loss. But the most easiest method for me is just drawing a circle on the face of the glenoid. In an end-face view, classically on a CT, you can understand how much of bone loss is there by just analyzing the area or the quadrant where the lack of bone is seen and taking a percentage of this. So typically, if the radiologist reports to you a 20% bone loss, you know that this is for Latarjet. This has already been covered by Mihir. So now, if you're talking about an arthroscopic assessment of the same, this is Stephen Buckett's picture from the year 2000, where he just used a graduated probe to measure the distance from the posterior labrum to the bare spot and the distance from the bare spot to the anterior labrum. And in this case, particularly, you can see that 5 mm of bone was deficient. So 5 divided by the entire circumference, which is roughly around the entire radius, which is roughly around 30 millimeter. So we're looking at roughly around 15 to 16% bone loss in this particular case. So this arthroscopically, you can measure on table when you're doing a diagnostic scopy, whether this is amenable for a soft tissue procedure only, or the glenoid bone loss is significant that you need to convert to a bony procedure. So how good is Latarjet? Latarjet is an excellent surgery. It's not a very radical surgery like how we think it is. There is a beautiful meta-analysis which has been presented. It's studying more than 245 articles with 800 plus patients. They found that Latarjet has fewer recurrences of recurrences than the Bankart, which is the soft tissue procedure, and they have better return to spot. And Latarjet has, in fact, less loss of external rotation. In fact, that's what people say, that doing a Latarjet can result in stiffness, but it's not the reason. It's not the way in literature. Of course, it is a radical procedure. It employs using screws, and the graft can break, the graft can autolyze, and there are radical complications that we are looking at. But it is an excellent procedure to apply. So the second point two, which they pointed out, and which has been further reviewed in a recent Journal of Isakos article called The Classics. They reviewed this 2000 article by Stephen Bucket and Jody Beer, and they were just understanding how good this article was in analyzing bone deficiencies, and it it clearly indicated that the engaging hill sac is the point two that these authors had seen as a real reason as to why soft tissue procedures fail. So this is an entire arthroscopic finding where a hill sac, whether a hill sac is engaging or not, is a complete arthroscopic finding, and it cannot be assessed preoperatively. But the easiest method of understanding whether the hill sac is big or small is just direct measurement of the hill sac. But I like using a fair bit understanding of a circle, like the circle method on the glenoid. You can use a circle method on the humeral head as well. And if it is covering more than 30% of, that is, if it is taking off more than 2 quadrants, rather than quadrant, 2 portion of an 8 slice circle, then you know that there's a significantly large hill sacs. But how do we dynamically assess the hill sac? Like, how can you say on a preoperative test whether the hill sac is engaging or not? Is when the shoulder is abducted 90 degree, you know that the area of the glenoid that comes into contact with the humeral head is the tract. So the track is now related to the defect on the humeral head. And with this comparison, you can say whether the humeral head lesion, the hill sac, is smaller than the track, which is on track lesion. And if the glenoid, if the humeral head defect is larger than the track, and which is called off track lesion. And these are the off track lesions are the ones which we really need to take care of, and which we really need to employ an additional soft tissue procedure in addition to the Bankart, where we need to apply Rempli. But recently there has been further understanding about the on track, off track, where they say that there is something called distance to dislocation. In addition to the on track and off track, you can also see the amount of bone defect which is remaining adjacent to the humeral head. That is how much more of intact bone you have got, and based on that you can say whether there is a chance for a redislocation after a simple Bankart surgery. So this value has been placed somewhere at 8 millimeters. So if there is a medial side bone of less than 8 millimeter, one must be sure that these are nearly off track lesions. So understanding all this, we should also understand the terminology where there is bipolar bone loss, where there is bone loss both on humeral head and the glenoid. And these are classically for Latarjet only, and they cannot be amenable to a soft tissue procedure at all. Even with a bone loss between 10 to 15%, with a significant bipolar bone loss, it is known to redislocate with just a soft tissue procedure. So what is for bony soft tissue procedure only? The ones with less than 10% bone loss, with an on-track hill sac, there is a small defect which is covering maybe only 1 slice of an 8 slice quadrant in a circle on the hill sac, can be amenable for Bankart. What is for Bankart plus Rempli would be 10 to 20% of bone loss. And if they have an slightly off track Hill-Sachs lesion, this may be amenable for a Bankart plus Remplisage like procedure. But if you do have anything more than 20% of bone loss, and if you do have a bipolar bipolar lesion, you're looking at definitely a bony procedure like Latarjet. But the literature keeps evolving and they keep finding new reasons. Even these percentages keep changing from country to country. Some of the European nations believe that Latarjet is the only procedure that should be applied for recurrent shoulder dislocation, and there is no role for soft tissue procedures. But is 15% the new 20% is a new article which has come up there? This discussion has been there in literature about the subcritical bone loss, where they have analyzed patients who have had failures of soft tissue procedures, only soft tissue procedures done without Bankart, without a Remplisage. And they have found that the 13.5% bone loss also are cases which can have a redislocation with just a soft tissue procedure. Apart from this, there are other considerations that one should take into account while applying a soft tissue procedure or a bony procedure is the kind of athletic activity that or the demand of the individual. A less than 20-year-old contact athlete or a throwing athlete is definitely something that you may need to think something more than just a bony soft tissue procedure. Hyperlaxity is a component which we cannot assess or treat fully like Mihir has told, but we need to take these hyperlaxity component into account while applying surgical procedures. And the quality of the Bankart tissue, that is the quality of the labrum tissue in itself, is something that we can understand only during a diagnostic arthroscopy. So a diagnostic scopy has a great value in finally deciding what procedure may work. Like here, you have a flat Hill-Sachs with a decent labrum, and this may be something where you can apply a soft tissue procedure only and get away without a Latarjet or Remplisage. But when you have a fresh anterior inferior labrum tear and the large Hill-Sachs, here there is also a large chondral fragment anterior inferiorly and a decent size crater in the Hill-Sachs, which is also engaging, are cases where you need to apply soft tissue plus bony procedure. And if you do find large inverted pear-shaped bony defect or the engaging Hill-Sachs like I showed earlier, those are for Latarjet only. Thank you.
Sajid, fantastic talk here. I think this is a topic that we can have a whole 3-day conference on. Okay, and completely depending on which part of the world you're operating, what patient you're operating, what is your choice, that will depend. So what we can do is we have our faculty members sitting here. Sajid has given a very fair, good chart about 15%, 20%, the so-called critical, subcritical. So Sajid, what is your cutoff? Let's take it one by one. And let's stick to a single number.
15% if you ask me single word answer.
Okay.
Because I also take into consideration the demands of the individual. Like if you are talking about a low demand individual who is not talking about pro cricket or pro athletic activity, then I may even stretch up to 20% and may even apply a Remplisage and soft tissue procedure because that's what the Indian population demands us to do. Arthroscopic
Okay,
procedures.
so what is your kind of cutoff with respect
So
to the
something
general?
similar to what Sajir said would go more by what the occupation of the patient is. So if it's a low demand patient, not into any throwing sport or heavy kind of lifting, I'd still go with 20%. But yes, where it says 15%, because always you've got to give that margin of error where the actual measurement of the lesion has been done by the radiologist. So if it's say 15, 16, 17, somewhere over there, again, so I'll go more by what occupation of the patient, probably then offer a latter J.
Okay, so again, it's about 15 to 20. Dr. Sunirmal, what is your cutoff?
Sir, I still go with the standard 25%. If it's less than 25%, I usually advise that we should do a soft tissue. More than 25, definitely lateral jet. And occupation, definitely contact sports. I had a couple of wrestlers who had come with similar situation, but it was less than 25%. But then I advised them soft tissue procedure, and I've been following for a couple of years now. So reasonably they have doing well, but every one of them complained of restricted external rotation. So that one thing I saw that
So a
which is
lot of
better with
discussion.
lateral jet.
Agree. So
Yes.
there's a lot of discussion about restriction of external rotation with remplissage. But we've seen that, usually after about 2 years, the external rotation almost matches the other side. So coming to Abhishek, what is your so-called critical bone loss?
So if you ask me single number, then it is going to be 15.
And if I ask you two numbers,
Then it depends on the patient profile, because
absolutely.
then how demanding the activities are, age of the patient, um, strength of the patient. So multiple factors. But then it will range from say 15% to 20% or 13.5%. So if a hefty person, I would even consider say 12.5 or 13% as a critical bone loss.
So a typical patient coming to OPD, okay, we have a 35-year-old young fellow coming to the OPD. Okay, he's giving you about say 18% kind of bone loss. So let's see how our decision making changes. Fayaz, you are around because I can't see your picture. Fayaz?
They seem to be outside somewhere, so maybe.
Okay, so we are looking at a 35 kind of man coming with say a third or fourth anterior instability, not treated at all, no rehab, nothing. He comes to you. And the MRI CT scan shows you around 15, 18, 19 kind of percent, in between these two ranges. So now how would it change? He's a typical corporate office goer. So Sajid, what would your decision making be?
The 35 has completely changed the decision. This all discussion is if the patient is 20. And this literature clearly points out to 20 as a number.
No, I'm saying 35 years of age.
35 years of age is what I'm talking about. I was just thinking about the age only. If you are talking about 20 as a number, the age 20, then we are looking at all these values. At 35, 4-time dislocator, 18 to 20, even 25%, we may even think about a soft tissue stabilization. And that's what they need.
Okay, so that means you will go for a soft tissue procedure. Aditya, Abhishek?
Same, I'll go for a bankart with a remplissage.
35 years old, but a single time dislocator you're talking about, or multiple times?
4 times.
Third to fourth episode?
Third to fourth. So in this case, I would err on the side of remplissage along with bankarts. Although there can be reservations about doing a remplissage, but I feel that remplissage gives you additional security. And as you mentioned, we don't have any problems in long term. There's no restriction of movement as it has been described.
Correct.
So I am comfortable going in with the bankarts plus remplissage for this kind of a patient.
So would your decision making change, say with a 5 or 10% bone loss, with an engaging or an off-track kind of Hill-Sachs? Would you just go for a bankart remplissage, fourth, fifth dislocate, or would still put a bone block?
5% with an on-track lesion.
Off-track.
Off-track. No, off-track, then you 5% defect plus off-track, then you basically are putting a remplissage and converting that off-track to an on-track. That is what you're actually doing. So it won't change. Only if the bony bankarts is more, if the bone loss is more on the bankart side, on the glenoid side, then I may think of any bone procedure.
Okay, so I think we are relatively clear 15 to 20% is the kind of range, the so-called critical or the subcritical, whatever words we use. And yes, I think today as instability surgeons, you can't not know how to do a bone block kind of procedure. Now that can be open, that can be arthroscopy, is a different discussion. So I think that with that we'll go to the next talk. Dr.
Yes,
Sunirmal,
sir.
you can start sharing your screen. So Dr. Sunirmal is going to talk
Yes, sir.
about some very practical kind of tips on how he's going to manage loose body, something that we deal in and out. So Sunirmal, you can start it off.
Yes. Yes, sir. I'm extremely grateful for this opportunity to speak today. So my topic is for arthroscopic loose body removal. So I would like to start with a case study. A 58-year-old male, he came with a shoulder swelling and very mild pain, not requiring painkillers, and it has been there since couple of years. On examination, there was hardly any palpable mass, but there was definitely a boggy swelling, which was visible or which was felt on palpation. There was no pain on movements, and there was no impingement signs. When I got an X-ray, there were few loose bodies visible in the shoulder, and I got some basic investigations like CBC, SR, CRP to rule out any infection or inflammatory cause like autoimmune inflammation or synovitis. He never had any other joint involvement, so I was not suspecting of any polyarthritis, so I didn't investigate further. He was hepatitis B positive. So, which is the first investigation which comes into my mind is getting an MRI scan, because MRI we not only find out the number of loose body, but we can also find out the synovial hypertrophy, and also we can know if there is any cartilage destruction or severe arthritis in the shoulder joint, which can be missed on X-rays. Just to complete the list, ultrasound is another option, and aspiration can be done in few cases whenever we are suspecting an infection. In this case, it was not needed because the inflammatory markers were normal. So even I had to read, because normally we don't discuss loose bodies very frequently, and even I have never read much in loose bodies. So I found out that Dr. Milgram in 1977 had done a study of histologic examination of 119 different loose body specimen, and he found out that in 1977 this loose body examination were done, and Dr. Milgram, he suggested that the mainly he found out three causes. One is synovial osteochondromatosis, one is osteochondral fracture, and the third one is joint surface disintegration. On histologic examination, he found out that there were three different kind of cartilage found in the nidus of each specimen. So it was either a articular cartilage, which is a hyaline cartilage, or a lobular cartilage. So lobular cartilage, I read it's basically a cartilage which is covered by perichondrium, which is different kind of cartilage, and it is normally seen in chondromatosis, in synovial chondromatosis, and it is in normal human being, it is visible in the nasal septum, which is a lobular cartilage. And osteophytic cartilage, basically the osteophytes which are fractured. So three mechanisms was proposed by Dr. Milgram, where he suggested that there can be either fragmentation of the joint surface, or fractured osteophyte, or osteochondral nodular proliferation, which is basically synovial proliferation. So broadly, the structures, the exact content of the loose body can be either fibrin, or it can be a cartilage loose body, or it can be a bony loose body. The most common causes are osteochondritis dissecans, synovial osteochondromatosis, either a fractured osteophyte, or articular fracture, or a meniscal loose body. In shoulder joint, especially, it is more commonly seen in the inside the shoulder joint, intra-articular loose body, rather than a subacromial space loose body. So why do we need to remove the loose body? So there have been many articles which suggested that after loose body removal and synovectomy, patients have better function and better pain relief. And the second thing is that unless and until we do surgical removal of loose body and send it for histopathologic examination, we don't know the exact diagnosis. So there's a possibility of malignant conversion, especially in cases of synovial chondromatosis. So that's why removal of loose bodies are important. So this is an image where the loose bodies are visible in the subacromial space and they are adherent to the synovial tissues. And we actually have to use a shaver or a cautery to loosen the loose bodies, and then we can physically remove each piece using either artery forceps or a long grasper. So a couple of articles, one of the very initial articles by Dr. DJ Ogilvy. He's a reputed sports surgeon in Toronto. He compared two groups of patients. In 5 patients, he only did a plain loose body removal without synovectomy, and in 8 patients, loose body removal with synovectomy was done. And he saw that in group B, where in synovectomy was done, they had significant pain reduction, and there was no re-effusion, and re-synovitis was not visible in them, and the function was also better in those patients. And 3 patients out of the 5 patients who were not in whom synovectomy was not done, 3 patients, they came back again to his clinic for with a repeat synovial effusion and synovitis. And similarly, Dr. Ivan Bojanek in 2009, another article I saw, he published a case series of 5 patients with ankle loose body and suggested that in all the patients, he had used both anterior and posterior portal in the ankle. And a thorough synovectomy and debridement of the ankle joint was done apart from loose body removal, and there was a very significant improvement in the hindfoot scores. And just to finish the list, loose bodies are very commonly seen in knees. Shoulder loose bodies are comparatively less common. And knee being a large joint, we often miss loose bodies, especially in the blind spots. So Dr. Mariani and Gilkis, they were the first to describe the blind spots in arthroscopic portals. So they suggested using a posterolateral and posteromedial portal as well to cover all the blind spot. And in this article, it is a Chinese article from China, published in recently published in 2007. And they suggested that it's important to check the popliteal hiatus, also the posterior supracondylar recess, and the inframeniscal hiatus as well, which is the common spots where the loose bodies are missed. And they suggested that it's not only just removal of the loose body, but we have to do a thorough synovectomy, and because the loose bodies can be hidden inside the synovial pouch, and those removal of the synovial pouch and exploring the pouches are very important, and that's the role of the MRI. So we need to find out in our MRI where the loose bodies are existing. So yes, in this image, we can see the various portals, anterolateral, posterolateral, and a transseptal portal was also made, where from the posterolateral portal, we can actually look towards the lateral femur condyle and the septum behind the PCL and the capsule, and gradually that septum is opened up so that we can go through and through, and we can work. We can use one portal as a viewing portal and the other posterolateral, posteromedial as a for inserting the instruments. So just to finish, just one small video. I would like to skip the video, so it's because it basically shows how loose the synovial pouches are opened, and once the pouches are open, the loose bodies are lying inside, and they can be removed gradually. And I'd like to skip it. We forgot to show the transseptal approach. So here the transseptal portal is being made, where from the posterolateral portal, the septum is slowly debrided, and we can actually see the medial portal as well. Thank you. I would like to stop the
Thanks,
share
Doctor.
now.
Yeah. So thanks, Dr. Sunil. I think that was
Thank you,
very,
sir.
very crisp. Have you faced any situation where you're trying to extract your loose body and it keeps escaping? It's like a video game. So
Yes, sir.
so you have a little single loose body, after a recurrent patellar dislocation, osteochondral loose body, you're trying to chase it and it keeps moving. So what tricks would you let our delegates know that you can use to just trap it somewhere and remove it?
Sir, I've never seen any hidden loose body, but the one which is visible, I've managed to catch it quite easily till now. Once a incident had happened, which I don't speak very frequently, but the 11 number blade, it broke inside the knee joint when I was trying to make a portal, and that blade tip was constantly floating from one place to other place, and I had to spend literally 20-30 minutes to remove that. That was the only situation where I struggled a lot. But loose bodies, luckily, I've been, I've never struggled that much.
No, I think that was a very frank discussion. I'm sure all of us have faced this at some stage of our life. And I think the basic thing that you can do is you have your blade tied with a handle, or you use blades which don't come with a detached blade. Those ready-made blades with handles come. The
Yes, sir.
second thing, you don't want to twist your blade once you make your port. You don't want to twist it. You just go in, come out,
Yes, sir.
turn it, go in, come out. So you take a
Yeah.
180-degree cut, either transverse or vertical. So that is what you can do to prevent these blades breaking. Sajid, any experience you want to share?
I didn't have any experience of blade broken, but I have seen an X-ray of a blade broken, intra-articular knee.
Okay.
Intra-articular knee, yeah. But then we retrieved it from the posterior middle portal using a needle holder. We could get it.
Okay.
Nothing else was grasping it. A needle holder could get it. What is your experience, Mihir?
Oh, I have broken everything. I've broken blades, I've broken tips of instruments, I've broken anchors, and I think these are all teaching programs. We need to be very frank. What is most important is, you shouldn't give up. I think the first step that you do when you face with a broken instrument is stop your outflow. You reduce the turbulence, because what happens is, moment you see an instrument broken, you get very nervous. Okay, you get stressed out as it is. It's a stressful time that when you're doing an arthroscopy. The first thing I would suggest is stop your inflow, so the turbulence stops, and don't let your eyes go off the monitor. Okay, what happens suddenly? You start shouting at the staff nurse or your assistant. So I think very important to keep looking at where the broken piece is, and then very quietly take 2 breaths. Okay, and then you take some needles, you block that loose body into the lateral gutter, medial gutter, wherever it is. And then very slowly, you guide it into the suprapatellar process. From there, you get it into the intercondylar notch. Once you get it into the intercondylar notch, then it's almost game over, because you have your 2 portals from there, and you very gradually pull it out. So, and in fact, I would say I've my blade broken is when I was operating my very own orthopedic colleague, and he was watching the surgery while I was doing a surgery. So these are typically occurs, all these VIP syndromes. And I think it's very important that you have to get out of it and be very calm. That is what it is. So, when Dr. Sunirmal says, I have done this, I think every one of us gone through this
Everyone.
stage. And that is how you grow. And I think it's very important that we should discuss all these points with all our beginners. So I think with that, we had a very good discussion and a very good bird's eye view of almost everything relevant today in shoulder arthroscopy. We covered the basics. Aditya discussed all the diagnostic round. We covered instability, rotator cuff. Sajid gave us a very good insight into when to do what procedure, what is critical bone loss, and we ended with Sunil talking about a very practical talk about loose bodies. So with that, Dr. Sandeep is back. Sandeep, I think. We had a very good discussion. Any questions or anything that Sandeep wants to share? Where he himself is an arthroscopy expert.
No, it was very good webinar. I was live continuously. I was hearing, and all the talks were perfect. I mean, I also enjoyed a lot. So thank you very much, all the viewers, and please see you all during the WIROC 2024 at Westin.
Sure, sir.
Great.
Thank you all the speakers.
Thank you, all the faculty. So with
Thank you,
that,
sir.
I think
Yeah.
we'll